University in Washington, D.C. with a Master of Fine Arts in Photography. Reverend Donna received her Master of Divinity degree in Pastoral Theology from Drew Theological Seminary and was ordained at the Bethesda Baptist Church of New Rochelle, New York in 2010. Reverend Donna completed her clinical pastoral education training at JFK Medical Center in 2017, and she is currently the Hospice Chaplain at HMH JFK Haven Hospice and an Associate Minister at New Hope Baptist Church in Metuchen. Chaplain Donna knows what it means to be with someone during times of joy and times of sorrow. She knows how to be present and how to listen deeply. She knows how to be sensitive to the values of people with various cultural and faith perspectives as healthcare and end-of-life decisions are made. As a chaplain, teacher, artist, dreamer, thinker, and featured writer, Reverend Donna will share her insights and story as it relates to our topic entitled Compassionate Consent, How Spirituality, Religion, and Culture Inform Medical Decision Making. We welcome Reverend Donna Owusu-Ansah.
Good evening. Many thanks to the Goals of Care Coalition for this gracious invitation. Many thanks to my mentor and colleague, Reverend Dr. Annari Griesel, for the warm introduction, and many thanks to all of you gathered here this evening. Truly grace abounds in this room. I'm a Baptist preacher, so that means I could be here 20 minutes clearing my throat. But I'm here in my role as a hospice chaplain, and so I will keep to our time. I want to locate myself first in the work and in the room so that you know who I am and how I arrived here. I come from a family where advanced directives, medical decision-making, death and dying, like most African American families, is not discussed at all. I'm a woman who just recently in November sat at my mother's bedside while she was intubated and sedated in ICU for 4 days after an angioedema. Thankfully, she is alive and well and doing well, but up to that point, the only conversation that my mother would have about advanced care planning, despite all of my attempts, because I did attempt many times, was that she didn't want lipstick on in the casket. And so, and I would push her and say, Mom, you know, let's talk about this. And that was the only thing she would say. Now it's a little bit different. But as a practitioner, I understand why it is important for us to have these conversations. But as someone from a cultural and religious background where we don't talk about death or dying because to do so would invite death, or we don't talk about death and dying because we are waiting for God to perform a miracle of bodily restoration, I understand why these conversations are also avoided. And so there's a tension, and I believe that tension is where we should find ourselves having conversations, because I think that is what can help our patients and families. So I come to the room with some presuppositions. The first is that you care. The fact that you are here on a Thursday night means that you care about this, that you have the courage to have these kinds of conversations. The second presupposition that I come with is that everyone's voice matters, whether it is the same as ours or different from ours. A mentor that I had in seminary would always say to us that different is not deficient. And so everyone's voice matters. Also, what I'm going to say may not be earth-shattering. A lot of it we have heard from our presenters. And so it will be a reminder, but I think it's important to have reminders as we move forward in this great work that we are doing. And then, what I need you to know that this is not a talk on specific cultures and specific religions, but it's more general about the conversation for having conversations with families about discussing, deciding, and documenting. And then as a religious leader, I think in big ideas, right? I think in big ideas. I think about what is best for humanity, and that doesn't always jive with bottom line and dollars and cents and practices, right? So I do know that we work in systems, and we have to keep those systems in mind even as we think about what is best for our patients and families. And I also want to say that I think that for innovation in advanced care planning, that we may have to go back to some ancient models: storytelling, deep listening, and being present with our patients and families. So to orient us tonight, our topic is compassionate consent, because I believe it's about compassion, right? It's about the being of the person that is in the room in front of us, or the being of the family members who are in the rooms in front of us. And that we must have compassion to touch those beings. Buddhist thinker, theologian, author, and activist who is actually now in Vietnam preparing for his own death. He's gone home to prepare for his death, has left us with these words: compassion is a verb. He reminds us that compassion is something that we do actively. The root of the word compassion is compati, which means to suffer with. And I think in this discussion that we have to have deep care and concern to the point where we feel in a palpable way what our patients and families are feeling. So on compassion, the Dalai Lama has said love and compassion are necessities, not luxuries. Without them, humanity cannot survive. And in our current social climate, including healthcare, we are greatly lacking empathy and compassion, not on purpose, but because of time. Everything is rushed, everything is billable, everything is bottom line. I love my primary care physician, but I've noticed in the last 5 years that she spends as much time looking at her computer screen and typing as she does looking in my eyes. But in the lives of people, during times of illness, crisis, death, and dying, those are not bottom line billable events. They require compassion. Business and systems are important, but they cannot take priority over people. We have to learn how they can work together. Margaret Wheatley said, listening is such a simple act. It requires us to be present, and that takes practice. But we don't have to do anything else. We don't have to advise or coach or sound wise. We just have to be willing to sit there and listen. And as we heard from Dr. Collins earlier, it's going in the room, taking a seat, and listening to patients that makes a big difference. And I want to suggest that listening, embodied listening, is how we best show compassion to our patients and families. When we listen with our whole selves, our eyes, our ears, our hearts, our mind, and our soul, we can begin to feel what people feel and understand what factors might be shaping or hindering them from having the conversation and making a plan. So, compassionate consent. Theologian Nell Morton said, we hear people into speech. We hear people into speech. In other words, when we give them an opportunity to tell their stories, to talk about the bow tie and the crisp suit and the boots, right? That we can hear people into telling us what it is that they need, what it is that they want. With the understanding that showing compassion through deep listening is necessary to the process, the question I raise is, what factors do we need to consider? What is important in the lives of people that shape how they approach medical decision making? And for us, when we're with patients and families, who is in the room? What is important to them and why? From the time of our birth to the time of our death, we are cultural beings. Whether you're deeply connected to your ethnic heritage, each and every one of us is a cultural being. We are shaped, literally cultivated by our culture. And our culture affects not just how we move about the world, but also the decisions that we make at end of life and who makes those decisions. Our culture shapes who we are, what we believe, and how we behave. And at no point in human interactions do we take off our culture. And so if we never take off our culture, then why don't we as practitioners consider that culture as we are with patients and families? If culture shapes what we believe and how we process the world, we should interrogate culture and find out what it is that, again, may be helping or hindering a patient or family from making a decision. Culture is present in our thinking and our processing, illness, disease, death, and dying included. And so there are types of culture. If we think about an iceberg, there is objective culture. That is what we see. It's eye contact, greetings, volume, initiative, food, clothing, time consciousness. Those are the things we see. Those are surface things. Those are the places where we may actually have some stereotypes that come from making decisions about someone based on their culture. And then underneath the surface of the objective culture is subjective culture, values, feelings, authority roles, concept of truth, motivations, assumptions, belief about gender roles. And those are the things that when we're having conversations about advanced care planning, those are the things that are coming into play whether we recognize them or not. And then culture is also subject to change based on age, community, religion and faith, education, employment, and English proficiency. And so in order to increase participation in advanced care planning, I want to suggest that we go deeper and explore subjective culture and other factors. I would suggest that first we need to go deeper into self-evaluation as practitioners, partly so we know who we are. Who do we bring into the room when we're with the patient and family? And mostly so we don't impose our own beliefs about advanced care and end of life on patients and families. Then there's spirituality. I won't stay too long on these next two slides, but spirituality is dynamic and intrinsic. It's how we make meaning in the world. It's purpose-seeking. It's how we experience our relationships. And it's expressed through beliefs, values, traditions, and practices. It's where we hear people say, I feel, or I sense, or I believe, all of which come into play when making advanced care decisions. And then there is religion, which is a subset of spirituality, which is why we can say, I am spiritual but not religious, because we do have a value system but may not be connected to a particular faith tradition. But religion is a subset of spirituality, a system of beliefs, observed practices, expressed through rituals, it's in worship, it's communal, and it has a huge impact on making advanced care decisions. It's why it's important to get faith leaders involved in advanced care planning, right? We heard from Adina how the rabbi was in the room when they were making the decision. Partly because many people of faith, though we adhere to a particular faith, we don't know all of the doctrine. We don't know all of the values, but we don't want to do that which is wrong or against our tradition. And so it's good to have faith leaders involved, or at least explore faith in the conversation. So with those in mind, when we're with patients and families, trying to have the conversation, trying to get them to discuss, we want to be mindful that there are nuances within cultures and faith based on region, generations, and family systems, right? So just because someone may identify the same way you identify doesn't necessarily mean that they're going to make the decision that you make always. We want to be mindful of our own prejudices or comfort levels with cultural and religious groups that may help or hinder receptivity to the presence of that particular group. And we never want to make assumptions that a patient or family follows all of the rituals, traditions, and beliefs of their culture. My husband is Ghanaian. He's, at this point in his life, spent about an equal time living in America as he did in Ghana. And if his family knew how much he talks about death and dying, they would probably pass out. But he's become very comfortable with death because his culture has been changed and shaped based on where he lives now, but also who he's married to. So in vulnerability and suffering, because we are talking about suffering here, we're meeting patients and families at critical points in their lives, right? And the Buddha wrote, young and old, foolish and wise, rich and poor, all keep dying, right? Doctor talked about how death was the enemy. Death is not the enemy. Death is really where we're all going to head. As a potter's clay vessel, large and small, fired and unfired, all end up broken. So too soon, life leads to death. And with this in mind, we don't want to avoid the conversation, but we want to figure out how to have the conversation with the particular person in the room and find out exactly who they are and what's important to them. The Hebrew Bible says, you are dust, and to dust you shall return. We're dealing with vulnerability. And we want to be mindful of that vulnerability because as practitioners, advanced directive and 5 wishes and pulse, those are words that we are familiar with, that we handle every day. But they're not part of the lexicon of our patients and families, and we want to keep that in mind as we're having conversations. Frank Otasewski says, sooner or later we stop and turn toward the suffering. And I would say for us in this room, and I know, as I said before, I'm a religious leader, I deal with touchy-feely, higher level things at times. And so I know that we want to shy away from suffering, right? But there's power in telling the truth about a diagnosis. There's power in telling the truth about a prognosis and really then feeling with the patient and family to get to decision making. Being compassionate, making space for people to share who they are, all of who they are, as they discuss, decide, and document, I believe is part of the overcoming of the suffering. And I know I've said a lot, which probably sounds really impractical, but I promise it's not. So here are some practical suggestions. The first is to provide personal human connection. Be present, be tender, warm, relational, not to assure that there is no danger. Because if you tell someone that they have stage 4 cancer, there is danger there. Acknowledge that danger and be with them in it. Meet patients and families where they are. I now know to meet my mom at the conversation about the lipstick and work backwards. Right? Educate patients, families, and care providers about the implications of decisions. What does it mean to do CPR? What does it mean to intubate? What does it mean to put in a feeding tube? What do these things mean now and in the long run, right? Ask questions, listen deeply, and then ask clarifying questions, and then guide based on cultural, religious, and spiritual values. Some questions to ask: how are you feeling? And if that doesn't get at an answer, how are you really feeling, right? Sometimes adding the really will get someone to open up to you. What is important to you? And if someone doesn't answer that question, you can ask, is it important for you to have quality of life? Is it important for you to do everything possible? Is it important for you? You can fill in the blank. What are your goals and your hopes? And sometimes people don't know what their goals and their hopes are. So you can ask them, what do you not want? Right? Sometimes people know what they don't want, but they don't know what they do want. Right? What are you afraid of? Ask that question. What gives you pause? And those questions will lead to, I believe, conversations that will advance the cause of advanced directives and living wills and 5 wishes documents. In essence, we want to be mindful of the cultural, religious, and spiritual lens through which we view advanced care planning. It's important to know who we bring in the room when we walk in the room. We want to be familiar with the cultural, religious, and spiritual backgrounds of our patients and families. And that doesn't mean we need to have a fact sheet. That's simply asking them, who are you? What's important to you? And then lastly, listening with empathy and asking clarifying questions when necessary. Thank you so much.